Hello, my name is Joji Kuramatsu from the University in Erlangen. I'm working as an attending physician in the Department of Neurology at the University Hospital in Erlangen. We're running a dedicated neurological ICU at our neurological department. It's a great honor and for me to be able to present our study results here in this ESOC forum. And on behalf of all the collaborators who participated in this study, it's my need, of course, to express my severe gratitude to all collaborators who participated in this large effort. So the title of our study is Association of Intraventricular Fibrinolysis with Clinical Outcomes in Intracerebral Hemorrhage Patients, an Individual Participant Data Meta-Analysis. So what's the methodological structure of our study? We conducted a systematic review and identified studies based on our predefined eligibility criteria. And we only came up with 3 studies based on a systematic review, and 2 PIs of those studies contributed data to our analysis. In order to be able to conduct exploratory analysis in a broad sense and to identify patients who potentially benefit from intraventricular fibrinolysis, we as the lead investigators, to tell you who they are, Dan Hanley and Wendy Zi from Johns Hopkins, and Professor Huttner from the University in Gießen, and Professor Schwab and Dr. Stefan Gerner. We decided that it wouldn't be feasible to conduct a IPD just based on those 2 studies, and therefore we conducted another search for large multi-center and prospective and high quality studies in ICH in general. And we asked for participation, and we integrated individual patient data from large ICH cohorts. And we finally ended up with a sample size of 1,500 patients for our IPD analysis after incorporating 7 more ICH cohort studies into the IPD data set. And all of those 1,500 patients were patients older than 18 years who had ICH in a supratentorial location, had intraventricular hemorrhage as complication with occlusive hydrocephalus, leading to the treatment of placement of an external ventricular drainage. So those were the patients that we selected, and we dichotomized the treatment into those patients who received intraventricular fibrinolysis, the use of alteplase according to the CLEAR protocol, which was 1 milligram 3 times a day in most of the patients, and compared those to patients who received placebo treatment within the CLEAR trial framework or standard of care at those neurological ICUs within those cohort studies. So our primary outcome that we investigated was 6 months functional outcome dichotomized into an MRS 0 to 3. Now I'm looking at the results already. So we conducted a rigorous statistical attempt to adjust selection bias in this cohort, because we had, of course, differences in patient characteristics that were included into this study. Patients that received IVF treatment were of the same age as the control group, but they tended to be, ICH tended to be more often in a deep location, basal ganglia hemorrhage, and the ICH parenchymal hemorrhage volume was slightly less than in the control group, and IVH, the intraventricular hemorrhage volume, was larger in those patients treated. Glasgow Coma Scale neurological status was evenly distributed. So when we look at the outcome results, first of all, just for a graphical depiction, we compare here a 1-to-1 propensity matched cohort. And what we did appreciate just graphically, that we had a significantly increased rate of favorable functional outcome defined as MRS 0 to 3, roughly at just above 40% in the IVF treated group, compared to just above 30% in the standard of care group. And this also analyzed by a doubly adjusted model, which adjusts for confounders that predict outcome on the one hand, and also are associated with the propensity to receive treatment. So this is a doubly robust model. We investigated the absolute adjusted treatment effect in this cohort, and we did appreciate a significant increase in favorable outcome by 9% in the entire cohort. So adverse events within 30 days, we did not appreciate any significant differences between those cohorts. And when we look at the exploratory analysis, we did appreciate, I believe, 3 important findings, which then are discussed regarding our results, and also discussed in the context of CLEAR-3 as the only large-sized randomized trial leaving or giving us neutral results regarding functional outcome. So one aspect is ICH volume, because we did see larger effects of IVF in those patients with larger volumes above roughly 20 cc's. And regarding IVH volume, also patients with larger IVH volumes above roughly 16 cc's to above 30, those were the patients who more robustly improved due to intraventricular hemorrhage. But most strikingly, we also investigated the time window from symptom onset to receiving first IVF dose, intrathecal alteplase. And what we did find was a robust association that the earlier you treat patients with IVF, the more likely they are to benefit in terms of functional outcome. Secondary outcome analysis, ordinal shift analysis, provided an adjusted odds ratio of 1.7 to improve across the entire range of MRS estimates. Mortality was significantly reduced with an odds ratio of 0.5, so roughly halved. And when we now look at this robust finding regarding treatment-associated effects with intraventricular fibrinolysis, this graphic shows an adjusted model, doubly robust, which exemplifies that IVF treatment, especially within the first 2 days, significantly improved functional outcome. And now we had the possibility, as we also included CLEAR, 335 patients from the CLEAR framework, to actually analyze this time treatment effect of this 48-hour window in the RCT cohort. And when looking at the absolute treatment effects, we did see 15% improved outcome for the overall IPD cohort, which was validated in CLEAR trial patients only, which also showed a significant effect of 13% absolute treatment effect in those patients. And also in those early treated patients, we did not appreciate significantly increased adverse events. Therefore, we can conclude that potentially those patients, especially treated early, are a target population that should be potentially investigated further in future randomized studies. And just for clinical benefit, after stability CT, hemorrhage, ICH is stable, then treatment with intraventricular hemorrhage should be initiated fast, even in those severely or in those patients.